Buon pomeriggio a tutti.
Good afternoon, everyone. Thank you very much for being here today in this session. I am going to talk to you about a technique that was created 4 years ago, as my friend Dr. Leonardi said, which is called SFALT, Sclerofoam Assisted Laser Therapy, which is a kind of endovascular vein which is tumescent free. We all know that over the last 10 years, the methods to treat VCI have completely changed. Over the last few years, we saw the creation of a number of endovascular methods, which you can see here, from radiofrequency, laser, to the use of vapor or LAFers, venous seal, so all sorts of things, mechanical, foam, as usual, and then 3 different types of glues. So we really have a plethora of elements that we can use. All those methods have yielded great results over the years, but only laser and radio frequency that were created first have a number of studies and sufficient follow-ups so that they can be held, that can be considered as liable treatments. They are quoted in the major guidelines with a good degree of recommendation. Those endovascular methods totally changed the panorama, replacing what was the only treatment that we had at the time, which was stripping. That has totally disappeared in some countries. Less than 1% of cases are treated that way, even though in some cases I'd say that it's still necessary in some few selected cases when there is no valve that can protect the operation that we're performing. No valvular valve, no femoral one, no pre-terminal one, no terminal one. It is quite clear. If we avoid performing protection surgery, further problems often come up. Recurrences or relapses, that's what I'm referring to. Why was SFALT created? Because after laser treatments or operations, I didn't like to see edemas on the thighs of the patients, probably due to tumescent anesthesia. On the other hand, we are using laser, which is becoming a more and more refined tool in terms of lead and power. But we also have a very invasive method, which is tumescent anesthesia, that with 200 to 500 milliliters fills up the venous area. I started in 2004, and over the years I've used all possible tumescent anesthesia possibilities that I had been given, or I have been gaining: long and short needles, syringes, pumps, echo-color Doppler. And I saw that, all in all, the only painful moment of the intervention was limited to the injections into the thighs that were unpleasant for the patient. But there is no correspondence between the mini invasiveness of laser and this huge quantity of liquid that is injected into the saphenous area. Furthermore, we know that seeing what happens with endovascular fiber is a cornerstone of our procedures. That is to say, if we compress with tumescence the vein in the groin, we don't really understand whether the fiber is working and how it is working. Hence, we have no parameter, which I deem very important. Another chapter is the following. Tumescence is not without complications, one of which is what we're seeing here. That is to say, when the fiber breaks, the laser fiber is extremely resistant. It can be mistreated, if you will, but it won't break. However, if we touch it with the needle, which is what often happens during the use of tumescence, it breaks unexpectedly. What happens when something like this occurs? When we use broken fibers, the tip or the point reaches 400 degrees. It is covered in plastic, so the laser burns it and part of the fiber is detached. That is what happened probably in the 40 cases reported in literature during such procedures, endovascular ones. Those are the reasons why I tried to look for, to find different treatment. So in October 2014, I started using SFALT, which is the very beginning of my experience with it. We have 7 centers in Italy that use this method. They have been growing, and we have reached a remarkable number of treatments reached and performed, which is around 1,500. What changed actually? We only changed tumescent anesthesia. Why do we use it in the first place? First and foremost, to reduce the diameter of the vessel, and on the other hand, for some anesthetic purposes. Hence, we changed the reduction of the vessel with an injection into the vein, and we actually inject sclerofoam, and we adopted as anesthesia intravenous sedation. So, sedation is a big word, but it has become a daily practice for us in all first aids and orthopedics and endoscopy units. And for example, in digestive units, where 80% of the patients ask to be treated with sedation. Patients really appreciate it because they don't perceive any pain, and no discomfort is perceived in terms of being in an operating room. So we firmly believe that there is a strong connection between those short operations or interventions with a moderate level of pain and sedation, in particular endovenous sedation. So the objectives of this study were to check the feasibility of the use of SFALT without tumescence and checking the spasm effect caused by the sclerosing drugs and foams, hence testing 2 different sclerosing agents, always in the form of a foam. In order for us to find A new use for this laser. The endothelium is already torn by the presence of the foam. That's what we focused on. And we discovered that there is a great interest and great synergy between the use of foam, which is active onto the endothelium, and the laser that impacts the vessel wall. Well, now the procedure is always the same. We use a catheter which is inserted into the vein with a 6 French introducer, always the use of 1470 diode laser, and fiber is 1 to 2 centimeter below the epigastric vein outlet, and we close with roughly 200 joules the GSV exactly in that point. Here is a short animation. Well, actually, no, it's a real video, which won't last very long. Let's see how metal fiber is introduced after the puncture is performed, and you see the fiber which is positioned with an echograph at the junction with the epigastric vein, the superficial one. So this method avoids anesthesia, hence time frames are reduced. Roughly 10 minutes, which is another reason why tumescent anesthesia is not used anymore. Sedation is therefore very mild in this case, easy. You see the positioning of the fiber with the use of the device 1 centimeter below, as I said, you can see it there on the left, and the creation of a clog. We are also creating this foam with the Tessari method. So 2 syringes, 5 ml each, 2 ml of sclerosing agent, which we used here, polydocanol, as well as tetadetylsulfatum, sodium tetadetylsulfatum, and an injection of foam. You see that after the injection, the vein is restricted, and it's remarkable, losing 50% of its diameter, roughly, over 50% even. See how the foam fills up the collateral veins, which are insufficient as well and that are not protected by the valves. So this helps us out in completing the type of procedure that we're performing. Once we create the spasm, the fiber is retracted as usual, and effluences are 50% of what we generally use. Roughly 5 to 7 watt, with 40 to 50 joule per centimeter. Obviously, phlebotomy is performed afterwards, or sclerotherapy, depending on the case. Here you see how in just 1 minute the vein is reduced and it practically disappears. You can only see the laser fiber after the injection with the foam. Here you see the animation. Actually, we've already seen it. What are the advantages then? The following. When we create a shrinkage plug on the cranial saphenous vein, we limit the diffusion of endothelial catabolites like endothelin and histamine and so on and so forth. Hence, well, we maximize the effect of the foam. At this point, when we inject the foam, we have performed a brilliant saphenous sclerotherapy operation, so we can use Fibroven 3% with a closed saphenous vein, and we could just stop here because we already have a perfect therapy in place to close the saphenous vein. We also have a synergic action of our laser, which acts and impacts the endothelium. Let's say after 2 months, often we see that the vein disappears. Here you see a few personal cases, 850 cases over the past 4 years. And we have observed a number of things. For instance, that after using the foam, the diameter goes down by over 50%. There is no difference amongst between the two different drugs that I quoted in terms of spasms. And at follow-up controls, that is to say 7, 21 days and 3 months, and after a year, all the patients, and in particular the latest ones, presented total occlusion of the saphenous vein. Only 3 cases displayed complete recanalization. We didn't observe any major or minor complications, and you see that practically no hematomas are to be seen. Here you see the cases. 850 legs on 610 patients, average age 55. You see a 2-to-1 ratio in terms of gender, and the caliber 6.7 millimeters, 5 to 14. The trunk mediumly 5 millimeters. I always prefer to operate below the knee, and it's always percutaneous. Never a surgical one in my case. Here you see the follow-up after 20 months, on average, where we have 3 cases of complete recanalization, which I deem due to a bad functioning of a fiber whatsoever, 11 partial recanalization cases, and 23 relapses on the inner branch, the ancillary one. That depends on where we operate with the laser and where the branch stems from. Obviously, depending on the single cases, we may have relapses, depending on the positions. I can now say that the absence of side effects leads us to think that this method could be used with brilliant results. The sclerosing liquid induces remarkable spasms on the vein, and foam and laser can be used together. There are no problems. Actually, they work in synergy, so we can reduce the fluence to low levels, really low. Not just that, but after a month, during the follow-up, as you can see in the picture on the right, well, you see that there is a halo around the vein. Probably this indicates that we can still shrink the fluence of the laser. The fact that we are closing this vein protects us from the presence of foam or catabolites in the system. Thank you very much.